So we'll request Dr. ASHRAF to give us his presentation.
Good evening, everyone. I am presenting a retrospective cross-sectional study on the outcome of DALK patients with intraoperative DM perforation. Deep anterior lamellar keratoplasty is preferred in cases where the disease is restricted to anterior layers of cornea. Some benefits of DALK over penetrating keratoplasty include a quicker recovery of vision, a lower risk of immunological endothelial rejection, and a lower susceptibility to traumatic sequelae. They do, however, have a somewhat higher learning curve than the full thickness treatment. During DALK, there is always a risk of intraoperative DM perforation. In cases of large perforation, many surgeons prefer to convert to PK. We present a study wherein DALK was successfully done even in patients with paracentral macroperforation of DM. DM perforation can occur at any stage during the surgery. However, if the perforation is identified and managed adequately as shown in this study, conversion may not be necessary and outcome of such patients may be excellent. The aim of the study is to evaluate functional and anatomical outcome in patients undergoing deep anterior lamellar keratoplasty with intraoperative DM perforation. The material and methods used, study design was retrospective cross-section observational with a small sample size of 8 patients studied at AIO, RIMS, Ranchi. Patients included were those who underwent DALK surgery and those with intraoperative DM perforation. Excluded patients were those with concurrent corneal diseases like active infection and those with central macroperforation involving visual axis. Due to lower perioperative subjective approval, the pentracam's astigmatism value was determined, and in order to lower intraocular pressure during surgery, all patients received preoperative IV mannitol to lower the risk of iatrogenic lens injury in the cases where conversion to PK was necessary. Peripheral paracentesis was used to introduce an air bubble into the anterior chamber right away, and layer by layer dissection was used to perform further surgery. With the exception of advanced keratoconus where the same size was employed, donor tissue was prepared using a trephine size that was 0.25 mm larger than the host trephine size after the host bed DM was revealed. All patients were given topical antibiotics 4 times a day for 2 weeks and steroid topically 6 times a day for 3 months with slow tapering dose, and the patients responded well. These are the results showing preoperative best corrected visual acuity and post-operative BCVA in the cases. And this is a chart showing a preoperative endothelial cell count and post-operative cell counts in different cases. This is a chart showing preoperative astigmatism and post-operative astigmatism in different cases. When the endothelium is healthy, DALK is recommended for corneal diseases. Corneal scars from superficial trauma or healed infections like healed infectious keratitis, anterior and stromal corneal dystrophies, and ectatic conditions like keratoconus and pellucid marginal degeneration are among the conditions that can be treated with DALK. Inverse big bubble technique is a well-liked method for cleaving the stroma at a specific depth for DALK. During trephination, air injection to produce a bubble or anterior stroma removal, the DM may be punctured with scissors, particularly at the location of partial adhesion. We can manage small perforations by decompressing the anterior chamber and carrying on with the process. It is necessary to convert large perforations to PK. The technique and the planned depth determine the likelihood of DM perforation during DALK. According to recent research, the rate of instantaneous conversion to PKP following perforation varies between 0% and 100%. Conclusion: post-operative best corrected visual acuity and astigmatism were found to be better and statistically significant. According to a prior study, injecting air into the anterior chamber to see the posterior corneal surface resulted in a mean cell loss of 22.5% after 3 months. Decompressing the anterior chamber and carefully dissecting the remaining stroma can help treat an intraoperative DM perforation during DALK. Limitations faced in this study are a small sample size and short period of follow-up. Due to existing gap, there is a chance of double anterior chamber creation, which will go away on its own in 4 to 6 weeks, providing an excellent visual recovery. If the perforation is identified and managed adequately, as shown in this study, conversion may not be necessary and outcome of such patients may be excellent. These are my references. Thank you.